All right, good afternoon to all of you. Good afternoon, all of you, everybody. Good afternoon, and welcome back to the GDC English classes, in which we are having right now Pharma Rank Booster. That's a series for you, in which we will be doing the complete pharmacology revision, right? And I welcome you all again at the 3 p.m. class, in which we'll be doing the drugs acting on congestive heart failure, right? So give me the attendance, guys. Give me a thumbs up, give me a hi, so that I can know whoever is present over here. Hmm? Give me a hi or give me a thumbs up so that we can go ahead. Yep, welcome back. Yes, chalo, come on. All right, Safrina Slima. Okay, Safrina is here. Subhashri is here. All right. Okay. Then anybody else? Give me your identity. Give me your identity, guys. Minakshi. Okay. Good afternoon. Good afternoon. Hi. Hi. And who's there? Darwaza kholo, है ना? Unmask the door. Unmask the functional groups, है ना? Which phase of reaction unmasks the functional group? That's your phase one reaction, right? Ah, chalo, tell me one. So three are present over here. Baki six are sleeping, isn't it? Baki six are sleeping, isn't it? Hmm? Yes. How's it going, guys? How's the preparation going on? It's your last touch-up phase, last touch-up phase जो women's करती हैं ना, the women's do at the end, है ना, touch-up. So that's your touch-up phase going on right now. And 3 days more. 3 days more. 4, 5, 6. That's it. Around 7 early morning, you'll be going on to your centers. And 9 to 12, you're having your examination. And after the 12 p.m., you'll have a lot of smile on your face. Why? Because at the end of the GPAT examination, you will all will think, yes, I have cracked this one. I have cracked this uh, GPAT examination for sure, and now I am completely being relaxed for now Niper days, right? Good afternoon, Suvarna, Tamale. Okay, okay, guys. Chalo, guys. Let's start with this one, Anna. Let's start with this one, and let's target onto the drugs acting on congestive heart failure, right? Chalo. Let's go ahead now. So congestive heart failure, that's a what? That's a progressive disease, right? That usually does not happen all of a sudden, right? It happens progressively. It takes time to be happen, right? That's why it is written over there. That's a chronic progressive condition, right? Chronic progressive condition that affects the pumping power, and the heart pumps, everybody knows that heart pumps, right? Pumps of your heart muscles. So while often referred to the simply as the heart failure, and whenever you can say like your pumping goes affected, pumping got affected, that's your heart failure. Kabhi kabhi when you brake in your bike, when you just try to stop your scooty, at the time or at the red light, so you just do the brake, but all of a sudden you realize the brake are not working, the brakes get failure, that's your pumping power also get reduced. That is what related towards the heart failure, right? Now, CHF, especially refers to the stage in which fluid buildups around the and it causes the pump inefficiently. What happens over there? Okay, Pir Pasha. Okay, okay. It's interesting. Pir Pasha Hasha. Sorry, I'm not being able to, uh, you know, pronounce your name correctly, maybe. Okay. Sorry, Piparsha, right? Okay. Piparsha Shah. Huh? Isn't it? Piparsha Shah. Okay. So in CHF, there is an inadequate or ineffective contraction of the heart muscle takes place, leading to a reduced cardiac output. Yeah. What is cardiac output, guys? Can anyone tell me? What is cardiac output? Hello, Krishna Bhale. Welcome back. Welcome back. Yes. Cardiac output, guys. Cardiac output. What is cardiac output? Hello, Krishna Bhale. Yes, what is cardiac output, guys? Cardiac output, and there is a stroke volume. We do have some stroke volume. Now I am talking to you in Spanish accent. They specifically used to uh, pull, pull themselves on the T word, the, like this, right? So heart rate into stroke volume. That's your cardiac output. Smith Ongle. Sumiti Angole. Okay. Hmm. What is the full form? What is cardiac output and what is stroke volume, guys? What is cardiac output and what is stroke volume? Hmm? Hmm. Chalo, come on, guys. Fast. Tell me the answers. What is cardiac output and what is stroke volume? That I want definition of that, right? So now, what does it do? What is cardiac output? What do you understand by that? I'm not asking about the formula of this one. Hmm. Chalo, fast. So cardiac output is nothing but the amount of blood yeah, pumped by left ventricle in 1 minute, right? In 1 minute, that's your cardiac output. Stroke volume, amount of blood, that is being. What is preload and afterload? I will let you know. Don't worry. Stroke volume is the amount of blood ejected out in one beat. In one beat, that's your stroke volume, right? Now, if I talk about the preload and afterload, right? Preload. Acha, what is preload? Preload is something that you know that blood pumped per second. That's your stroke volume, right? Now, if I talk about preload, what happens? Okay, this is your right ventricle, right? And right ventricle, so you have pulmonary artery over there, right? Pulmonary artery over there toward the lungs, right? Towards the lungs. And it goes for the purification of blood into the lungs, right? And again, you will be having pulmonary vein, which goes into your um, which goes into your लेफ्ट एट्रियम, राइट? लेफ्ट एट्रियम है ना, ये तुम्हारा लेफ्ट एट्रियम है, लेफ्ट एट्रियम में जाएगा। उसके बाद में यहां से ब्लड, वहां से ब्लड कहाँ जाएगा? लेफ्ट वेंट्रिकल में। इट विल बी गोइंग ऑन टू द लेफ्ट वेंट्रिकल, राइट? बट the amount of blood which will be staying over there, where? Left atrium as well as in the lungs, and that is your preload, right? Whatever the amount of blood is being there in left atrium and uh, pulmonary vein, that is your preload. Yeah, resistance of the blood to move ahead, yani resistance of the blood to fill in your left ventricle, that is your preload, right? Now afterload is the resistance. Again, afterload is also resistant. Afterload is also a resistance when the blood doesn't able to move ahead from the aorta. From the aorta, that's your afterload. Is it all right, Krishna Bhale? अगर तुम्हारा ब्लड लेफ्ट एट्रियम में रहा या पल्मोनरी वेन में रहा, दैट इज योर आफ्टरलोड रेजिस्टेंस, है ना, वहां से ब्लड मूव नहीं कर पा रहा है, राइट. एंड इफ योर ब्लड डजंट एबल टू गो अहेड फ्रॉम अयोटा, है ना, थ्रू आउट द बॉडी, दैट इज योर आफ्टरलोड. इज इट अंडरस्टैंडेबल? इज इट ऑल राइट, कृष्णा? इज इट ऑल राइट, एवरीवन? इज इट ऑल राइट, एवरीवन? टेल मी. Now, I hope it is understandable to you guys. Now, heart failure may be primarily due to the systolic dysfunction or as well as a diastolic dysfunction. Systolic dysfunction is your contractile, right? Contractile one, and diastolic is your relaxation type. When your blood fills up, when your blood fills up into the chamber, that's your diastolic dysfunction. Okay. Now, what is cardiac remodeling now? What is cardiac remodeling now? So, cardiac remodeling, it is defined as a group of the molecular, cellular, interstitial changes that manifest changes that clinically in size, mass, and geometry and functioning of the heart after the injury. So what happens when the cardiac muscles, है ना, you know that these are your cardiac muscles, right? These are your cardiac muscles. So if the muscles won't act properly, if the muscles won't act properly, what will happen? What will happen? The muscles will not contract much, right? Muscles won't contract much, and the amount of blood will be filling over there only, right? Heart contract nahi kar raha. Why isn't able to contract? just because of the just because of the dysfunction of cardiac muscles. Cardiac muscles has lost the elasticity, lost the contractility, right? So what happens here? The blood gets filled up. Here you can see the blood gets filled up. That's your cardiac remodeling, right? Mass change ho gaya, size change ho gaya, geometry gets changed, function of heart gets changed, right? Okay. Now, backward failure, that's your distended vein with increased preload. What happens when your blood gets pushed backside, है ना? That's what I told you over there कि blood in preload, what happens कि blood जो present होता है, that is present in your right atrium, right? Sorry, left atrium. Yeah, that is present in your left atrium after coming through the pulmonary vein. But your blood gets pushed backward into your pulmonary vein. That is what? That is what? Preload, right? That is what? Preload. Push backward, that is known as the backward failure. But if I talk about forward failure, narrowed arterioles with increased afterload. Increase afterload, what happens in that? Your blood doesn't able to move ahead towards the aorta, है ना? That is the forward failure. Okay. So this one, nitrates, ACE inhibitor reduces the preload, whereas ACE inhibitor as well as the other vasodilator also reduces the afterload, right? Whereas if I talk about nitrates, right? Nitrates reduces both pre as well as after load. Okay, this is an important statement you have to remember, right? Now, digitalis and dobutamine. Digitalis and dobutamine increases the cardiac output, and which was earlier cardiac output was decreased, now it will be increasing the cardiac output over here, right? Dopamine also has some effects on renal power. That's so increased renal blood flow will be seen over here as well. So that's why diuretics, whatever the amount of blood and fluids gets build up over there. Diuretics will be promoting the sodium and water excretion over there, right? Cardiac output is 5 liter. Yes, that's right. Okay. So that is what the pathophysiology, mechanism of action of drug used in cardiac heart failure. Okay. Aim of for treatment. Main aim is to decrease the work of heart. And the workload should be decreases down in the CHF, right? By decreasing the preload as well as the afterload, and to decrease the mortality by reversing the cardiac remodeling. Okay. Now, classification of the CHF drug. Drugs acting on CHF. Diuretics, obviously those are the things. Loop diuretics, thiazides and aldosterone antagonists. Loop diuretics, furosemide, bumetanide, torsemide, thiazide, chlorothiazide, hydrochlorothiazide, metolazolone, aldosterone antagonist, spironolactone or eplerenone, right? Arteriolar and venodilators, ACE inhibitor, angiotensin receptor blocker, direct renin inhibitor, sodium nitroprusside, right? That's what I'm talking about. Arteriolar as well as venodilator, right? Now, specifically venodilator, that's your nitroglycerin isosorbide dinitrate. Arteriolar, that's what I told you. Nicorandil, minoxidil, and hydralazine. To be precise, diazoxide is also the drug. Diazoxide is also a drug which is known to be as the arteriolar dilator, which are potassium channel opener to be precise, right? Beta adrenergic blockers, metoprolol, bisoprolol, and carvedilol. These are your beta adrenergic blockers. Sympathomimetic amines, dopamine, dobutamine. These are your sympathomimetic amines. Cardiac glycosides, digoxin. Phosphodiesterase inhibitor, imamrinone and milrinone. These are known to be as the inodilators, if you remember. Yeah, these are known to be as your inodilators, right? Vasopressin receptor antagonist, V2A receptor antagonist, that's your tolvaptan and conivaptan. What is vasopressin, guys? What is vasopressin? Why there is a need to antagonize this one? What is vasopressin and why there is a need to antagonize vasopressin? So tell me first. Hmm? Tell me first. Why there is a need to inhibit the receptor of vasopressin? Hmm? Chalo guys, tell me. Antidiuretic hormone, that's your vasopressin. But why there is a need to inhibit that one? Why does it need to inhibit that one? Hmm. Why does the need to inhibit that vasopressin? अरे यार, vasopressin is your antidiuretic hormone, right? Antidiuretic hormone. तो antidiuretic hormone क्या करेगा? It will be decreasing down the sodium and H2O levels excretion, right? So if we inhibit that one, what will happen? This condition will be reversed. Yeah, and that's what we want, right? It will be now increasing sodium and it will be increasing sodium and sodium and water excretion. And that's what we want, right? Now, natriuretic, that's your necessary type. That's an important thing to remember. Now, mechanism of action of drugs. What happens in the acute heart failure? Contractility gets decreased. Huh? Compensation में क्या होगा? What will in the compensation? Sympathetic activity will be increased, right? Sympathetic activity will be increased. So what happens? So alpha and beta receptor will be come into play, right? So if I talk about alpha receptor, vasoconstriction takes place and arterial constriction takes place, venoconstriction and arterial constriction. So preload and afterload, right? Preload mein nitrates will be doing their action and hydralazine will be doing the action on afterload, right? If now again sympathetic activity was increased, stimulation of beta 1 receptor to maintain the cardiac output. To maintain the cardiac output, yeah, beta blocker क्या करेगा? It will inhibit the beta 1 receptors, right? So remodeling stopped, right? And beta 1 is also responsible for the release of Jg cells, yeah, and Jg cells will be releasing what? Renin, obviously. And now RAS system activates. RAS system activates. Now angiotensinogen converted into angiotensin 1. ACE enzyme coming from the lungs, right? Coming from lungs, converting 1 into 2. AT receptors. AT receptor have direct action, vasoconstriction, preload and afterload takes place. Aldosterone indirect action, right? Aldosterone remodeling takes place and that leads to death. Aldosterone has a power to retain the salt and water. Now, what will happen in this one? Diuretics are a very good choice of things in which salt and water retention gets inhibited. And spironolactone is a aldosterone antagonist, you know that. And ARBs, angiotensin receptor blockers, that's your going to inhibit this one, AT receptors, right? ACE inhibitor is acting on ACE enzyme. So this is the mechanism of action of the drugs acting onto the different kinds of the pathways, right? Is it all right till now? Is it all right till now, guys? Hmm? Is it all right till now? Yeah. Yes and no. At least say no. Now let's talk about this one, guys. Cardiac glycosides. So you know that cardiac glycosides are the ones which are very much useful in your CHF, right? So digitalis purpurea leaf digitoxin, right? Digitalis lanata leaf digitoxin and digoxin. Strophanthus gratus seed strophanthus G as well as the 𝙂𝙀𝙎. Now, if this one sodium calcium exchanger, calcium, if I talk about this one, right, pumps over there, what happens here? Sodium and potassium, there is a pump. And here you have calcium and sodium as a pump, right? What happens in the condition when, potassium level gets reduced down, है ना? तो potassium level goes inside and sodium goes outside, right? Sodium goes outside and potassium gets inside, right? But if you inhibit this one, what happens? Digitalis inhibits the sodium potassium exchange by sodium potassium ATPase pump inhibition, right? What will happen? Sodium will be remain inside. If sodium remains inside, है ना, तो there is no need to more sodium over again. So calcium will also will take place over here again, na? Calcium will also not go outside. So calcium will also be over here. So there is a free calcium present over here now. Now this will be going into the sarcoplasmic reticulum and exaggerate more release of the calcium ions. Now if more calcium ion takes place, more contractility takes place, and that's why contraction, that's a positive inotropic reaction will be taking place with cardiac glycosides, and negative chronotropic. Heart rate must be reduced down, but conductivity, force of contraction will be increased, right? This is the thing. Now, drug interaction, if I talk about beta blocker with verapamil, or verapamil with the digoxin precipitates the AV block. That's an important thing to remember, right? Thiazides or loop diuretics with digoxin. Hypokalemia caused by diuretic may potentiate the digoxin toxicity, right? Hypokalemia. If there is a hypokalemia over present over here, that is going to increase the digoxin toxicity. That's an important point they have asked before, right? Okay. Cholestyramine, cholesterol, or digoxin. Cholestyramine, cholesterol, or digoxin reduces its absorption. Propanolol, verapamil, diltiazem, and disopyramide, indigoxin, these are additively depress AV conduction and oppose the positive ionotropic action, right? Calcium and digoxin synergizes with digitalis and precipitates the toxicity, right? Quinidine and digoxin increase the plasma concentration of digoxin, leading to digoxin toxicity. Atropine antidepressant drug, digoxin, increases the absorption of digoxin will be taking place. Now let's talk about the MCQs, guys. Here we have the first question. The following type of the vasodilator is not beneficial in CHF due to systolic dysfunction. Systolic dysfunction, contraction kind of a thing, right? So which one is not beneficial? Calcium channel blocker, angiotensin converting enzyme inhibitor, nitrate or hydrolazine. अगर सिस्टोलिक डिस्फंक्शन है ऑलरेडी, है ना, सो विच विल बी नॉट अफेक्टेड, विच विल बी नॉट अफेक्टेड गाइस, है ना, कॉन्ट्रैक्शन की बात कर रहे हैं, तो आउट ऑफ दीज ड्रग विच विल बी मोर अफेक्टेड ऑन द कॉन्ट्रैक्शन? सिंपल, वेरी सिंपल क्वेश्चन इफ यू सी अबाउट दिस वन. सिस्टोलिक है, कॉन्ट्रैक्शन की बात कर रहे हैं, वी आर बी टॉकिंग अबाउट द कॉन्ट्रैक्शन, राइट? सो विच वन इज इट? चलो कम ऑन फास्ट. Anyone? At least guess. Systolic में obviously calcium channel blocker will be there, no? है ना, calcium channel blocker, calcium responsible for the contraction, and if you block that one, relaxation takes place. But this is nothing going to be happen with that one if systolic dysfunction there. Systolic dysfunction is your contractile dysfunction. Simple. Okay, it's not B. Madhavi. Okay, dopamine is useful in oligouria, cardiogenic shock, congestive heart, cardiac failure, all of these. Which one is it? Very simple. Hmm. Dopamine is useful in oligouria, cardiogenic shock, congestive heart failure, all of these. That's your all of these, guys. Dopamine are very much useful in your oligouria, cardiogenic shock, and congestive heart failure, right? Now, drug used in the treatment of congestive heart failure include all except, okay, spironolactone, equinetine, ace-butalol और lisinopril. अरे ये तो बता दो यार, ये तो क्वेश्चन बहुत इजी है. This question is तो very easy, right? Which one? Hmm. Very simple, na? Equinetine, that's a correct answer. Okay. Which phosphodiesterase inhibitor can be used in congestive heart failure? Phosphodiesterase inhibitor. Midazolam, milnirone, mivacurium or miltefosine? Miltefosine. Which one? Midazolam, milnirone, mivacurium or miltefosine? Abhi we have talked about that's a inodilator. Right? That's your inodilator which are useful for that. So which phosphodiesterase inhibitor? That is generally what? Phosphodiesterase inhibitor 5, right? That's your milnirone, Anna. Who was there? Sesmita. Okay, that's your B. That's right. Milne. No. Okay. The drug used in remodeling of hard and congestive heart failure are all except beta blocker, ACE inhibitor, digoxin, aldosterone antagonist. बीटा ब्लॉकर यूज करते हैं, एस इनहिबिटर भी यूज करते हैं, एल्डोस्टेरोन एंटागोनिस्ट भी यूज करते हैं, तो विच वन नहीं करते हैं? कौन सा नहीं करते हैं भाई? विच वन इज नॉट यूज्ड इन कंजेस्टिव हार्ट फेलियर रीमॉडलिंग? Try to imagine that. Try to imagine that graph which we have talked about. Which we have talked about. Hmm. Beta blocker, ACE inhibitor, digoxin, aldosterone antagonist. Which one is it? Yeah, that's your digoxin, guys. Okay. Okay. Now, aldosterone antagonist used in heart failure and Conn's syndrome. Which one is used as an aldosterone antagonist? Aldosterone antagonist, diazoxide, bumetanide, eplerenone, or furosemide. Aldosterone antagonist, the name itself tell you. The name itself will tell you the answer. Aldosterone antagonist used in heart failure and Conn's syndrome. Diazoxide, bumetanide, eplerenone, or furosemide. Which one? Kalpana P. Okay. She's saying D. No, that's not D. That's not furosemide. Yeah, that's eplerenone. Very good. Anna, Sesmita, Sumit, and Samima. That's your C. It's not B, Sumit. It's C, right? Chalo, very good. Powerful cardiac stimulant. Cardiac stimulant, which will be a kind of the inotropic, positive inotropic, Hana, positive dromotropic, positive chronotropic, right? Powerful cardiac stimulant. Digitoxin, dopamine, epinephrine, or dobutamine. Which one is it? Which one is it? Digoxin, dopamine, epinephrine, dobutamine. Mm, that's your dobutamine, powerful cardiac stimulant. That's your D, dobutamine, guys. Okay. All of the following agents belong to cardiac glycoside except digoxin, sulfenthin K, amrine, or digitoxin. Very simple. ये तो very simple question. Now that's a very simple question, guys. चलो, tell me an answer. Hmm. Which one? That's your C, amrinone, which is a inodilator, right? Chalo, very good. Drug used in heart failure. Drug used in heart failure. Celiprolol, cartiolol, carvedilol, all of the above. Drug used in heart failure. Celiprolol, cartiolol, carvedilol, or all of the above. That's your all of the above. Carvedilol. नहीं, all of the above होगा. That's going to be your all of the above. Okay. Celiprolol भी use करते हैं, cardiolol भी use करते हैं, carvedilol भी use करते हैं. All of the above. That's going to be answer. It's not C. Digitalis overdose can be reversed by administration of. Okay. That's an important question, and they have asked this one. They have asked this one. That's an important. They have asked already. Hmm. Which one? Phenytoin, calcium, sodium, or Fag fragments of the digoxin specific antibody. Which one is it? Hmm. Which one is it? That's your D, obviously, right? Sure, very nice, very nice. Which of the following is the primary effect of digitalis in congestive heart failure? Primary effect of digitalis: decrease heart rate, increase force of contraction, decrease venous output, increase urinary output. Which one is it? That's a simple one. If you know, the cardiac glycoside increases the inotropic effect, right? Increases inotropic, decreases chronotropic, right? That's you know. So now, if you know that one, you will definitely able to answer this one. Which one is right? Which one is right? Kalpana, very nice, very good. Shashmita, very nice. That's your increased force of contraction of myocardium. Very good, very good. Now, the following electrolyte disturbance causes digitalis toxicity. Hmm. Which of the following disturbance can cause the digitalis toxicity? We have talked about that one, right? Hana? Ki that thing increases the toxicity, right? So is it hypocalcemia, hypernatremia, hypokalemia, or hyperkalemia? Which one? Hmm. Which one? That's yours. Sumit, that goes right. Hana? Hypokalemia is the thing which is increases the digitalis toxicity. Smriti Ranjan, very good, very good. Okay. Now, 𝙂𝙀𝙎 is a cardiac glycoside effective when given by following route. When given by following route, 𝙂𝙀𝙎 is cardiac glycoside. है ना? Effective when given by following that show IV guys. Okay. Chalo. Now, select the most suitable antiarrhythmic drug for counteracting ventricular extrasystoles due to ये कहाँ से आ गया antiarrhythmic का question? Okay, now this one. Severe digitalis toxicity is best treated with. Severe digitalis toxicity is best treated with potassium supplements, diphenyl hydantoin, quinidine, or 5 fragments of digitalis antibodies. Again, same question. Hmm, same question. Chalo, tell me. Tell me, tell me. Same question. That's going to be your D. 5 fragments of digitalis antibody. That's right. That's right. Very good. Digitalis is most suitable for treatment of CHF when it is due to. Digitalis is most suitable for the treatment of CHF when it is due to pulmonale arteriovenous shunt, thiamine deficiency, long-standing uncontrolled hypertension. कब ज़्यादा suitable होगा? That's you guys. Long-standing uncontrolled one. Okay. Now, drug causing afterload reduction. Okay, which causes afterload reduction? Digoxin, captopril, dobutamine, or furosemide. Afterload reduction. Resistance to go upward from the aorta. Resistance to go upward direction of blood from the aorta. That is afterload. So that is being reduced by which of the drug? Digoxin, captopril, dobutamine, or furosemide. Which one? Hmm. Which one? That's your captopril. Very good, Samima and Smruti Ranjan, Sesmita. Very good. Right? Captopril. Very nice. Which of the following agonist would be used for cardiogenic arrest, heart and a heart block? Which one? Kalpana, very good. Nahi, Kalpana, it's not a. Chalo. Alpha agonist, alpha 2 agonist, beta 1 agonist, or beta 2 agonist? Cardiogenic arrest हो गया है, heart block हो गया है, so that is going to be a which drug which is being used over there? Alpha 1 agonist, alpha 2 agonist, beta 1 agonist, or beta 2 agonist? Hmm. Which one is it? Which one is it, guys? That's obviously going to be your Sumit's answer. That's C. And here you go, the B1 antagonist, beta 1 antagonist, so that some kind of the contractility will be given, some kind of the power of to gonna contract, conduct, right? So that's going to be your beta 1 agonist. Okay. Okay. So that's it for this session, guys. And I hope I have made you clear. I hope this must be very much useful to you, helpful to you in order to revise the things. So this is all about the congestive heart failure and cardiac glycosides. We will be right back at 7 p.m. so that we can have another session onto the anti-arrhythmic drugs there. And at 9 p.m. we will be solving the model paper second today, right? And try to join over there, okay? Whoever is people, I'm requesting you guys to please join at 9 p.m. at the model paper discussion, and I will be doing there at that time. Okay. Thank you so much for joining, guys, and I hope I have make you clear around this topic. Yeah, satisfied with the session, guys? Satisfied with the session? This is not the MCQ class, Shruti Ranjan, right? This is not the MCQ class. This is the class of theory plus MCQ. That's what we have done, right? Okay. Why 23? It's not 23. It's another. See. It's 17 over there. The numbering is different with each question. Okay. Numbering is different with each question over here. That's not 23. Specifically, you are answered just like a questioning like a scientist. Hana? Why only specific 23? Give me the reason behind the specificity of 23, isn't it? Hmm. Smruti Ranjan? Don't. Okay. Chalo guys. Okay. ठीक है. Thank you so much, guys. Thank you so much for joining. And all the very best. And we'll see you at 7 p.m. and at 9 p.m. Okay. Thank you so much, guys. Thank you so much.